Hello everyone, it's me Dr. Ayaz Ahmed. I am working as an aesthetic dermatologist. Today I have selected another important topic of dermatology. The name of topic is Hailey disease. In this section I will cover its introduction, its epidemiology, clinical features, differential diagnosis, investigation and management. Hopefully you will learn and subscribe my YouTube channel. Introduction. So by definition, it is a rare autosomal dominant blistering skin disorder, also known as familial benign chronic pemphigus. It is first described by Hailey brothers in 1939, caused by ATP2C1 gene mutation. Epidemiology. Onset typically in second and fourth decades of life. It affects both sex equally or slightly more in males. It has chronic relapsing course. It is a rare condition. Prevalence is unknown. Pathophysiology. Mutation in ATP2C gene, one gene have been noticed. Defective calcium ATPase disrupts keratinocytes adhesion, leads to acantholysis, or in other words you can say loss of cohesion between skin cells, triggered by heat, sweat, friction or infection. Clinical features include recurrent painful erosion, fissures and crusting. Common sites are axilla, groin, neck, perianal inflammatory folds. Symptoms include burning, itching, pain, malodor, exacerbated by sweating, heat, friction. Always note that there is no mucosal involvement. This image describes the example of Hailey disease. You can see the wet erosion noted in the axillary area. There is also fissuring visible in this image. Hailey disease favors the area where there is skin pores. This is another example of Hailey disease. In this image you can see the crusted fissures and erosion located on erythematous base. This is another example of Hailey disease involving the folds of axilla. Here there is fine scaling and erosion. This is another example of Hailey disease. You can see the involvement of plaques in lower abdomen with erythema and foul smelling coming from these lesions. Always note that the lesions of Hailey disease are painful with fissures and crustaceans. Male patient case presentation. This was a case presented. A man of an age of about 32 years old presents with chief complaint of recurrent painful rash in axilla and groin for 3 years. Triggering factors were summer month, sweating and tight clothings. Family history was positive in mother. Examination finding was moist erythematous plaque with crusting in axilla and groin. Investigations conducted were skin biopsy, suprabasal acantholysis, classic dilapidated brick wall appearance. Genetic testing include ATP2C1 gene mutation. Rule out secondary infection, fungal or bacterial. Swab. Differential diagnosis include intertrigo, inverse psoriasis, pemphigus vulgaris, diarrheal disease and candidiasis. Now management. The management options are: number first is the lifestyle, second is the topical management, third is the systemic, fourth is the procedural management. Lifestyle modification include avoid heat, sweating and friction. Topical treatment options are steroid, tacrolimus and antiseptic wash. Systematic treatment include antibiotics or antifungal if infected, oral retinoids in severe cases. Procedural management include laser therapy, botulinum toxins or surgery in refractory cases. Prognosis and follow-up. Disease has chronic relapsing course, can be well tolerated or controlled with treatment. Quality of life can be affected by flare-ups. Regular follow-up for infection and treatment response is required. Now summary. Rare inherited blistering disease triggered by mechanical and environmental stress. Diagnosis confirmed clinically and histologically, requires long-term management and patient education. Thank you very much. Stay connected and subscribe my YouTube channel.